Good morning, everyone, and thank you for joining us for our first event of the day. Today we're going to be looking at how the private sector can advance equitable access to care, and this event is in partnership with MSD for Mothers and the WHO Country Connector on Private Sector Health. It also builds on lessons learned from the WHO Country Connector. So during COVID-19, we actually saw a backward trend. We saw an increase in maternal deaths, stillbirths, and maternal depression. And we've always acknowledged the potential that the private sector has and the potential that digital health has, but these are seldom integrated. So we're looking to dig into that this morning. And to start off our conversation, I'm going to call on stage my colleague, Alex Cabaret, who will have a discussion with us on something that's really close to my heart and probably a lot of people here, women health workers and leadership in maternal health. Alex?
Thank you so much, Rumbi, and good morning, everyone. Hope you're well awake, had time to get a coffee. I'd like to welcome on stage our first two speakers, Dr. Rupa Dutt, Executive Director and Co-founder of Women in Global Health, and Aissata Doumbouya, who works for Partner in Health in Sierra Leone as Director for the Maternal Center of Excellence, and also in charge of reproductive, maternal, neonatal, child, and adolescent services. So it's a big program. So please come on stage with me. Welcome. And for those who are not on brand, you can then visit the Country Connector booth and get your pin. I've put my pin there. Also have the Women Global Health one. Please sit down, yeah, take a seat. So I'll start with you, Rupa. And so you've created Women Global Health in 2015. Right, and I was just reading a report that you issued called She Shapes, where you're talking about the lack of women in global health decision-making positions, and seeing that there is about 70% of health workers are women, only 25% of people in positions of power in global health on decision-making positions are women, and only 5% are women from low- and middle-income countries. Right? So why is it important for maternal health that more women become in position of power, and how to break the glass ceiling? So that's an interesting point I'd like you to develop a little. We've interviewed you recently in a Devex article where you've developed a bit, but I'd like you to take this to the audience today.
Alex and everyone, it's really great to be joined by all of you this morning, and what I enjoy about Devex is you get straight to the punchline. So, Women in Global Health, we were founded in 2015 because we found ourselves, and I am one of the early founders of the movement, is that whether you are going into any place in health, whether it's the highest levels of decision making like the World Health Assembly, or at the community level and the national level, women deliver health and men lead it. I'm going to repeat that again. If there's one message that you're going to walk away with is women deliver health and men lead it. And we are losing out as a result of it. Losing out in many ways. Not only is it the right thing to do, women are 70% of the health workforce. You do score an A+ for reading the report, Alex. And I hope all of you will also score that way next time I meet you. And yet 25% of the leadership roles are held by women. And what that means is that women who have the expertise, they are seeing the impact of maternal mortality, the lives lost. We have heard there were millions and millions, hundreds of millions of unattended pregnancies just in COVID-19. We also are hearing in many countries maternal mortality rates are actually worsening. These women health workers are not only at the patient side, but many of them firsthand themselves are mothers, and they're seeing how broken the health system is. But you know what? They have no place to go to take that expertise and transform the health systems. The second thing we talk about, you said, why it matters. I hope in a room such as this, I don't have to convince you why it matters. It's more about how we're going to transform health at all levels, at the highest levels in decision making, places like the World Health Assembly, where we are seeing chief delegates of member states, governments to the WHO, World Health Assembly, being stagnant representation. We're celebrating this year that there's a 9% jump from last year, but in reality, when you look at data over the last 70 plus years, there has never been a point that that number of chief delegates has gone above 32%. So really, it's still the quarter glass ceiling. So this must change. And at the community level, what is happening, and at the local level, at national decision making, the same pattern repeats itself. And no matter how much training we get women to become leaders, they are facing gender barriers. For the first time, Women in Global Health did a report together with our chapters. And when we formed in 2015, we did this analysis with WHO and released a report that captured these exact numbers. And then now we have done a report with our country chapters, India, Nigeria, and Kenya. And to say it very blankly, it doesn't matter which cultural, background you're from across those three countries. While we had seen different leadership, ratios, overall we're seeing the same glass ceiling, and some will say even cement ceiling, and the gender barriers. So I want to give a couple examples of what type of barriers women are facing and being unable to proceed. They're facing the motherhood penalty. That's universal. So whether you have a child or not, you are viewed as one that potentially could be a carer at any point in time. And the pandemic has demonstrated that we lean on women more than anybody in society to be carers. We're also seeing high levels of sexual harassment and violence. And this one I really want to highlight for this room particularly. We know how challenging it is becoming to provide family planning. I live in the United States. I'm originally Indian, and to find myself coming from a country where I have more choices in India than I do in places in the United States. As a health provider, I'm a physician. I have seen my colleagues that are GYN, OBs, emergency medicine, even internal medicine physicians struggling with where they will practice because they fear not only legal risk, but personal risk. And we are hearing from organizations, our partners. We have an alliance of gender equality and universal coverage. Many of these partners are in the room, of over 200 organizations, and we're hearing from them that, for the first time, we are hearing about health workers. Again, majority women are providing these maternal care services, neonatal care services, are facing attacks and risk to personal lives, not only in places like the United States or just a handful, but actually in the 50s to 60s countries. So this is a really critical issue. And if there's a second message you walk away with is that when we talk about protecting health workers, we must talk about it, protecting women health workers, look at things from a gender dimension. And so I want to switch to some of the solutions. The first thing we can do is really start making sure that women are in leadership. And that takes bold actions. And it is possible. You have to do all women shortlists. It's fine because for centuries there have been all male shortlists. I'm going to repeat that again. For centuries, men have had the male bonus. It's okay if we have to equalize for a few decades. Otherwise, we'll never achieve gender equality. The second thing I want to talk about is the second solution, in addition to leadership, is the pay issues, especially this room, as you are feeling the urgency. 2030 is just around the corner. We know we are behind, and not even behind, but going in reverse directions. And if you disaggregate the data through an intersectionality, it is the poorest women and the most marginalized women that are losing their lives. And what we have to do is, address that. But the quick solution is to have women, the poorest women, subsidize health care. And when I talk about subsidize, I mean basically provide free care. Last year, Women in Global found that at least 6 million women are currently underpaid or unpaid. And I know, Alex, I'm almost at time, but I want to drive this point home. We cannot ask women, the poorest, to provide these services and further exploit them? How will these health workers, women health workers, be supported to really address these goals? So it's not only the right thing to do, it's a smart thing to do, and I hope I can count on each one of you in this room and your organizations to end all forms of unpaid work in our sector. Thank you.
Thank you. Thank you, Rupa. You addressed several points here, and some of the issues you mentioned trickles down into the health systems. We've seen that a lot of health workers are leaving their countries to go into better paid jobs in developed countries. So we see that with health workers from Africa. There was a report recently about health workers from Zimbabwe and Nigeria going to the UK. I live in Spain. We see that in Spain with lots of workers coming from Latin America to come and work in Spain as health workers. Aissata, you did the opposite. You went from the UK back to Sierra Leone to work as a nurse and lead that center. So can you tell us more about why you came back and what you see on the ground?
Thank you, Alex. Yes, you're right. I did the opposite. So I trained and lived in the UK for over 30 years, but I'm also from Sierra Leone. I was born in Sierra Leone, and Sierra Leone, as we all know, has for many years had one of the worst maternal mortality rates in the world. Thankfully, that is changing. We are improving and have drastically halved the number of maternal mortality deaths. However, we still have a long way to go. And what am I doing there? As a midwife, I'm thinking, why do we have so many women dying in childbirth in Sierra Leone, in Africa? What is it that we're missing? What is going wrong? And what can we do? What can we do? What can I do? As a very experienced midwife in the UK, what can I do to help to change this? So in Sierra Leone, I'm working with Partners in Health, and working in Kono districts, which is one of the most deprived districts within the country. It's the furthest one that you can get to. After that, you're basically out of Sierra Leone into another country. But it was also an area that was devastated by the civil war and also by Ebola. It's a mining area, so you have a lot of problems around teenage pregnancy, sexual exploitation. Women are used as objects rather than seen as people. So working within there, trying to change not just maternal mortality, but also how women think of themselves, how young girls can, what can they do to stay in school rather than have an unwanted baby, and improve their chances and their lot of sort of growing and developing and achieving so much more in life. So we're currently working to build a fantastic maternal and neonatal center called the Maternal Center of Excellence. And the idea behind that is to ensure that we can bring quality, the same standard of care that I would expect to give to any woman in the UK. Why can it not be done in Sierra Leone? Why can the nurses, the doctors, and all the other clinicians that work in there not have access to the same resources, the same equipment, the same teaching and training as we can have in any developed country? So working with Partners in Health, working with Build Health International to build that center that will become an icon and a blueprint for the entire Sierra Leone, and for other partners, that when you think about, I am going to help, I'm going to do something, really do something that's going to make not just a short-term 2-3 year grant difference, but a long-term, long-lasting, invested in the future, invested in the development of the staff that are there and in the women that are there. So this center is being built, as I said, by Build Health International, but it is being built mainly by young women. 65% of the people that work there are young women from within the district, young girls that had previously dropped out of school, that had no career prospects, are now learning how to build, how to do simple engineering, how to do welding, how to work with electricians, plumbers, and really putting that effort in and saying, we're building this place for women and children. So women building for women. And that is something that is really, it inspires me, it inspires everybody who goes there and sees it, and makes us think that, you know, when you think about, I'm going to make a difference, invest in making a long-lasting difference that is going to keep on growing and giving. Thank you.
Thank you, Saita. And congratulations for building that. I wanted to ask you another question, but I think we're at time, unfortunately. So I'll ask you just one last call to action, a call to action for people in the room, and then we'll move to the next panel after that.
Well, I'm going to give a shout out to Asata, and I said she is a woman in global health, and she is talking about women built for women. She is the proof of concept, and there are so many of these women in our communities, in this room. Let's make sure we talk about investing in women health workers, not as a cost, but an investment with a great return. We talk about the triple gender dividend. This is the third message I want you to walk away. The greatest return we can get when we invest in decent jobs for women is not only will we achieve health for all, we will also have women's economic empowerment, but every health job that is formalized creates 2 to 3 other jobs in other sectors. So when we talk about this is the triple gender dividend, and let's not stay in the sidelines. Let's make sure we build with women. I really like that, Asada. You are showing that example, and I hope I can again call on you, all of you, to make sure that we talk about investing in women health workers, not as a cost, but an investment with great return. Thank you.
Thank you. Asada, anyone to share last remarks?
Yes, just to build on that, to say not just as health workers, but invest in women as leaders. Women as leaders in healthcare work really does make a difference. I'm a living example of that. I'm called Mama MCOE. So yeah, everyone knows that, this is having women as leaders really does make a difference in not just decision making, but also in the quality of the products that you have at the end, because we know what is best for us and we know how to go about getting that done properly. Thank you.
Well, thank you both. Thank you so much. Well, Rumbi, you're next. Welcome back to the stage.
Thank you, Alex. I'm not sure if I was fully awake when I did that first intro, because I actually forgot to mention that I'm Rumbi Chakamba, the associate editor here at Devex. So hi, everyone. But definitely all those statistics and the call to action from Rupa and Esata definitely woke me up, and I'm excited for the next conversation. So the question that we want to answer is how can the private sector advance equitable access to care? And I have a dynamic group of speakers here to help me answer that question. So I'm going to call on stage David Clark, Acting Unit Head of Health Systems Governance and Policy at WHO, Hassan Balkayet, co-founder of Southbridge, A&I, Aminatu Sa, West Africa Hub and Senegal Country Director for PATH, as well as Vivian Ihekwezu, Managing Director for Nigeria Health Watch. Please join me on stage. We do have stairs. I jumped on, but we do have stairs. Please come down. You can come and sit right here next to me. There you go. And David, there's a mic right there for you.
Thank you.
Thank you so much. David, I'm actually going to start with you. I said we're going to speak about lessons learned from the Country Connector, but can you tell us more about what the Country Connector does and why it adds so much value?
Just to say, we set the Country Connector up initially during the COVID emergency, and a lot of the emphasis on it was to try and help to engage the private sector to deliver vaccines and COVID tools. But obviously, and this is kind of often not spoken about enough, during the COVID emergency, and Deepa mentioned this, there was a massive downturn in the services that were available to women and children. And if you think that most of maternal and child health in LMICs is actually delivered in the private sector, it's incredibly important to have the private sector involved in those services, particularly during the pandemic. And we did see a massive disruption in these services during the pandemic. Governments in some countries did a lot to try and bring the private sector into the response to maintain essential health services, but in many cases they didn't. So that's why the Country Connector was set up in the first place. I think it's incredibly important now for two reasons. Across the COVID emergency, really showed the importance of making sure that you bring together all of the health system, all the health actors to deliver services, so it can be efficient and so people can actually have access to services. During the pandemic, it was very fragmented. Although the private sector in many countries wanted to help, the government didn't always bring them into the response. It was so we've been trying to encourage more a whole of health system approach to working to improve healthcare. The second thing I wanted to very briefly say is now we've got a credit crunch. So I've heard during WHA a lot of the delegations saying there's no money for services, including services for women and children. So we need to look at how we can use the scarce health resources that we have as efficiently as possible. And I guess that's why the Country Connector exists, to connect the public sector and the private sector together to achieve these resources. And I want to stop there because I want to make lots of time for my fellow panelists to have their say.
Thank you so much. That's really considerate. So Vivian, I'm going to jump to you. Nigeria Health Watch has been talking a lot about how the government can leverage the private sector. Do you have any examples or success stories from Nigeria on how this works and the advantages it brings?
Yes, pleasure to be here. Just also following up from what David mentioned in terms of scarce resources. So, Nigeria has a population of over 200 million. Health has historically been underfunded. This year, 2023 budget, 5.75% of the budget will be spent on health. This is comparing to 4.7% last year. It's an increase, but it falls short of the budget declaration in 2001, where they were supposed to spend at least 15%. So health is severely underfunded. And this is where the private sector can and does play a role in bridging a lot of those gaps. If we are to achieve our SDG goals and UHC, those gaps can't be filled with the public sector on its own. So the private sector can and does play a significant role in different ways in terms of improving skills and capacity, partnering with the government to improve services, innovation, using mobile technology to increase access to people in rural areas. So an example I want to talk about is an intervention that was actually funded by the Gates Foundation and also MSD for Mothers. We have a modern contraceptive prevalence rate in Nigeria of just 12%. So there's a severe unmet need for family planning services. And this is especially the case in rural and hard-to-reach areas where young girls and women don't have access to family planning services. And historically, 40% of women actually access family planning services in the private sector. And in a lot of these communities, there are existing structures, informal, but structures that actually do deliver certain services. If you look at data looking at health-seeking behavior in Nigeria, often when people are ill, they go to the local chemist or the local pharmacy. So in many rural areas, you have what we call patent and proprietary medicine vendors or community pharmacists, and they already are the first port of call often to deliver health services. So with a project, an initiative called Integrate E, access to family planning service was scaled up. But this wasn't just done by enabling them to supply services on their own. So the government, working with the Pharmacists Council of Nigeria, actually trained them. So through an accreditation process, they looked at the existing community pharmacists and PPMVs and looked at their skills level. And through a tiered accreditation model, and training them depending on the level of education of that community pharmacist. So you have those who have a low level of education, then they were able to deliver just basic services, just refilling women's contraceptive needs, to like say the third tier where they're able to do more family planning services. So they have a bit more experience and they have to be pharmacist technicians. So this enabled access to family planning services to be scaled up in 2 states where it was piloted, in Kaduna and in Lagos. And this is really important because we have a very high fertility rate in Nigeria. The average woman in Nigeria has about 5 children. Of course, when you look at that figure, it does hide some regional differences, but 5% is very large, given we have a population of over 200 million. And so using the informal private sector, because they are informal, but they deliver a critical service in communities. So over the 4-year period where the program was piloted, they were able to enable 200,000 women who have access to family planning services and avert 17,000 unintended, unplanned pregnancies. And in addition to that, because we spoke about the migration of health workers, we have a similar problem in Nigeria. So using this model, they were able to have scale up the task shifting and task sharing policy. So they were able to now be part of the service delivery for family planning services. So it's not just in primary healthcare facilities that you can access these services. So this is an example of how the informal private sector was brought in to expand access. And this program has now been scaled up to 11 states in Nigeria and is a model of how the informal and public sector can work together in increasing access to a service that women should have access to whenever and wherever they need it.
And a great example of impact, 200,000 women and 17,000 unintended pregnancies. I'm going to jump to you, Aminatu. So PATH focuses a lot on digital health. So how can SMEs who work in the digital health space fit into all this?
Thank you, Ruth, and thank you for having me. I would just tell about a joke that I always do when we do coffee breaks. I don't know if you notice, people are stirring their coffee like this. Some of the people, some others are doing this, some others are doing this. And why are they doing that? Why is it different? For what? And actually they have the same goal, to melt the sugar. This is why they do that. And actually this is what all these SMEs want to do. They all do something because they want to do something about our health system to be more resilient, more efficient, provide services. So it is really at goodwill. And again, this is where maybe the problem is, because we want all to do something, but not always in a coordinated way. And it is something that is a kind of workload, bring more workload to the health workers, and they are resisting to this digital. And this is the new trend. There are lots of entrepreneurs, lots of new ideas, lots of people, young people who want to do something. And this is where PATH is trying to really work with the Ministry of Health in Senegal on enterprise architecture, trying to bring all these ideas going to the same direction and build an architecture that will lead in the production of applications, approach that are useful to the health system, that are bringing values, that are interoperable with the DHIS2, which is the District Health Information System. And it means lots of shift in the mindset. It means also people being ready to provide open source applications, because when it comes to pay for an application, we know that it's not viable knowing our system. So how we bring all these entrepreneurs to work together and produce end users usable application and accessible to the health system, and that is really adding value to the health system. And this is how there is a group of all this organization working around digital, who are continuously, regularly discussing among themselves on how they can collaborate and work directly with the Ministry of Health. So we have the unit for digitalization there, and trying to create these connections and agree on what is most needed for our health system.
So Hassan, she brought up a really important point that they're trying to solve problems. And I left my question for you last because I think this is the problem that they probably have. You work a lot with startups through a program called I3, but what does the funding landscape look for them?
Thank you so much. I'm very happy to be here. So I would like to speak about I3. I3 is an Innovation in Africa program. It's funded by the Gates Foundation and partnership with MSD, AmerisourceBergen, and a lot of other partners. And it's actually tackled the same issues about putting startups in the continent under the spotlights, right? And I think it's quite important because we did a study actually 3 years ago to understand why there is not enough risk-tolerant funding that goes to these startups. What are the financial issues that SMEs and startups are facing? And one of the main issues is actually, when you spoke to those companies, is that one, they don't have access to funding from local financial sector. That's the first point. And the second element is that they just don't know how to operate with public sector or how to operate with other big companies. So we created this program, a Pan-African program, touching all the continents. So in order to select every year 30 startups that will receive or that receives actually a grant from the foundation, and that's a way to spread funding across the continent, but also have access to markets, to the Nigerian governments, to the Moroccan governments, to Kenyan governments, etc. Access to different big corporations, etc. And being followed on a daily basis, basically. And the impact to that is quite important. First, it's led by African, let's say, accelerators and partners. It's very important because for the first time, actually, the grants are not decided in Seattle or somewhere. It's decided closewhere, and the selection comes actually from the ground. Two, we created activities and events to match the demand with these startups. And it's very, very important because then, as of today, after 8 months, more than 30 MOUs have been signed between governments, large corporations, etc., and these startups. These startups also receive, of course, communication support, and they've been raising so every startup received $50,000 grants. Based on these 50,000 grants, they were able to raise collectively more than $10 million now, right, after 8 months. And I think that's a sign of how coalition of partners can support private actors to actually tackle public health issues, because these companies were selected based on their impact that they can have on public health issues. And 50% of companies actually are women-led. And that's one element that is very important for us, is in the selection process to have the women-led criteria as a very important criteria. And when you say women-led, it's not just the manager is a woman, but it's also in the shareholding. It's very important.
As soon as you said 50% of the companies are women-led, I was immediately impressed by I3. So back to the Country Connector, David. Can you take us through some of the lessons that you've learned from the initiative and maybe give us an example of how it's helped?
I think the lesson that we've learned is that we need to do more of what we're doing now. This has been the problem of not integrating the private sector into health system efforts and efforts to improve everybody's health, including women's health, is that it's been really patchy. That governments haven't really taken it seriously, or they haven't known what to do. And Hamid was saying that the private sector don't know how to work with governments. It's the same, it's the other way around as well. Governments don't know how to work with the private sector. So I think the biggest thing that we are trying to do on our side as WHO is empower governments to work with the private sector in a productive way to improve population health and women and children's health in particular. In relation to how we can have an impact, I think we have an impact because we are very much country-focused. It's called the Country Connector for a reason. So our mission and the support we give is driven by countries' requests and needs. So I think that's probably the critical thing we're doing. We're not developing global norms and products and driving them down. We're responding to country needs. And I just wanted to do one more thing before I pass over.
You have time.
Oh, thank you. So I just wanted to acknowledge the women that I work with. So they're in the room. And so the Country Connector is very much an initiative which is being powered by women. Most of the people in my team are women. So I just wanted to ask Anna and Aya and Gabrielle and Yulia to stand up, please. Come on. So can you give, yeah, so I think, yeah, so I just want to give them all a clap. So we wouldn't be here today without these great young professionals who have made a huge contribution to the success of the Country Connector so far. So thank you.
Thank you. And back to women in health, I'm going to jump to you, Vivian. So we were talking about how the private sector doesn't know how to work with the government, but the government doesn't also know how to work with private sector. And I think it's also the same for patients and consumers. There's a conception that the private sector is expensive. And could you talk us through that and tell us, is it really expensive for you to rope in the private sector?
Expensive, I say, expensive is relative. I think the death of a woman is a cost that you can't put a figure on. So in Nigeria, it's interesting how David talked about the Country Connector and how the private sector and the public sector don't often know or work together very well. And there's an example that I can give. In Cross River State, the Cross River government, actually, it's interesting that, the Country Connector looks to help public and private sector work together. And a lot of women go to access services often in the public sector, but a lot also, probably 6% people go to access maternal health services in the private sector, because the private sector is often available. And, you talk about cost. The public sector is not necessarily in Nigeria free, because often when women go there, they are charged for services. So in Cross River, what the government did, there was a program they initiated, supported by MSD for Mothers and USAID. The Saving Mothers Giving Lives project looked to integrate and strengthen the referral system between the public and the private sector. Often women may go to the public sector, access services, they may need to also use services in the private sector, but there's that poor referral system. And you asked about the cost. The cost is often the death of a woman. So we talk about the 3 delays that lead to women's death. So what the government did by strengthening that process is not just strengthening the referral process, but also using and working with the private sector to address the 3 delays that lead to maternal death. So for example, the first delay, women even going to the facility in the first place. So they increased demand. So working with community-based organizations, they were able to increase demand for women actually going to health facilities. Another challenge that often leads to the death is transport, so getting to a health facility in the first place. So working with community-based organizations to support in ensuring that women are within about 2 hours, not more, to a health center that can deliver quality, because we always say that private sector or public sector, which is better. The key element is that ensure it's quality assured. And another thing they did, talking about the third delay, training. When women get to the health facility, the quality of care can sometimes be a challenge. So this is how they sought to address those gaps. And over the 3-year period when this project was initiated, and it's continued thereafter, there was a 66% decrease in maternal mortality in the 100 public and private hospitals that the government worked with and strengthened the public and private sector working together. So that is an example of how you talk about the cost, but the cost is relative to often the service that that the women have access to.
I think that's a really important point, quality care, because we always talk about access to care, but I always think it's important for us to highlight that we're looking for quality care. And I just want to go to Senegal, because we've seen an example of how this is working in Nigeria. Can you take us through some examples in Senegal of how the government is trying to integrate SMEs?
Yeah, I wanted just to comment about the relationships between the private and the public. They don't know maybe how to work together, but they also don't trust each other. And that's so the point about even on the data, how we are not sharing data between the public and the private sector, and yet we know that in above all urban settings, there are lots of private players. And people tend to go private because it's quicker to get an appointment, to get the care that we want. And yet we are missing this bunch of data that is very useful for decision making, to understanding where the needs are. So it is a challenge. In Senegal, there is a unit who is trying really to connect to the private health facilities and the public health facilities, and also a unit who is trying to regulate those. And coming back to the digital side of things, we think that the private sector, because people are paying much more quality services than public, it's not always the case. And this is where we need to do these connections and provide these solutions that exist, that are offered to the public, to the private sector at the same time. And not only these digital solutions, but also to equip them, train them to be able to feed in data in our system. When I take, for example, the laboratories, the biggest laboratories are private laboratories. All this data is missing in our health system, and this has led to also very poor in terms of data, in terms of forecasting, in terms of making provision, in terms of knowing where the gaps and the issues are, and even on specific diseases. So Senegal is trying to correct that. Senegal has put in place a unit for digitalization, trying also to organize all the players around digitalization. And very recently, the World Bank has given a big fund to support that strategy for digitalization that will look at not only the health, the data, sharing data, but also telemedicine. There are lots of things that the SMEs can do to contribute, to develop chatbots to remind women about their appointment, giving antenatal care, using voices and using our local languages for awareness raising. Lots of things needs to be done. And we need to trust each other to make this happen.
Trust is a really important thing. I actually never looked at it that way, that there might be this gap in trust between the private sector and the public sector as well. But I want to go back to you, Hassan, because Amanatu has actually gone through a lot of what I was going to ask you, but then can you identify some of the gaps that SMEs can fill? And in addition to that, we're actually running out of time. So I'm going to ask you, what's your call to action for leaders here in Geneva? How can they help this collaboration happen? Because we've established that it works, it's important, but how can they make it happen?
So thank you for the question. So Southbridge is actually a company, a Pan-African company that works a lot with governments, right, and working on policies, etc. But we also believe that the private sector is actually critical, and especially the SME sector and entrepreneurship in the continent, because just let's say the gap of investment is so huge, and it's impossible to be filled only by the public sector. Just to give an example of Morocco, already 7% of the national budget is to healthcare, and 50% of care is going through the private sectors, not only the public sector. So even in a developed, or let's say intermediary country, we have this situation, and it's even bigger in African countries because, you know, the informal sector is so important and the resources are scarce, so the private sector will always have to play this role. So knowing that, you know, the private sector is already operating across different sectors. So natural play is actually through medicines, pharmaceuticals, etc., but also in care and providing care, but also with what we're seeing now is social enterprises, like going into community health workers, what you said about, you know, providing this kind of, let's say, women appointments, this kind of elements, and actually funded by the governments or international institutions. Now, SMEs, in the private sector, basically we have two kinds of companies. You have structured companies, more and more bigger, having access to financial services, but also having access to private equity, and we know, and this, there are companies now coming into that. But the large majority of actors are actually SMEs. And these SMEs, today, they are facing to grow, and first of all, they are very adapted to the continent. They know how to operate. but also they are facing one big issue in terms of growth, which is their access to funding, right? And this access to funding, it comes for three reasons. One, scarcity of funds in this financial sector also, and when you have scarcity of funds, the banks tends to provide their funds from their balance sheet to the large corporations, right? And it's even though they say we have a SME policy, etc., the reality is that 90% of their funds goes to the large corporations. The second issue is that the financial sector in general doesn't know how to assess the risks of these companies, right? And the risk assessment of these companies. So they just say, okay, I don't know this, the health sector is too technical, I don't know anything about it, I'm not going to provide any kind of resources to that, so I'm not going to fund that. And the third reason is also, companies tend to fund themselves through their suppliers, right? And the suppliers, the global suppliers, don't provide any terms for Africa because they take the country risk is important, inflation, depreciation, everything, and they say, okay, I want to be paid now, right? So what we are currently putting in place with the Gates Foundation also, but other partners, is actually a big working capital mechanism across the continent to mitigate the risks. And the idea is actually to provide working capital and manage these funds through local partners, local asset manager, professional asset managers who are able to assess the risks of these companies and give funding to these companies, to these distributors, etc., small distributors, local wholesalers, platforms, startups, etc. And it's very important because today the impact of not doing that, and we see that is actually on the prices and the affordability of medicines in the continent, which is very high. And it's only high because working capital funding is not there. And we have actually a lot of middle agents, coming in because they are providing the working capital to do that, and we end up at the end with prices 3 times what it costs, what it comes actually when the products come in the country. So my call is actually we acknowledge actually the role of the private sector, but let's find solutions, financial solutions, actually to link and to develop the private sectors. And here the role of governments, our partners, is very important because maybe half of these fundings is going to be in local currencies because we are speaking about distribution in local. And here, if we can dedicate funds actually managed by professionals to make it very performant, etc., but targeting these companies who are actually serving the public goods. Last elements about it, this fund is going to be an impact fund, so that means that even the management team is not remunerated based on the performance of the fund, but on the impact that it's doing, and that basically the rates that you can provide to the private sector can be lower than the market if they are, for instance, women-led or serving maternal and child issues, etc. And I think that's also an innovation coming from other sectors that the health sector can benefit from.
So David, the Country Connector is all about encouraging this collaboration. Do you have a last call to action?
Yes. This week, I think, the UN high-level meeting resolution on UHC, the draft came out, and there's nothing about this initiative or this topic we're talking about today in the resolution. So my call to action is to say to leaders, can you please pay attention to this issue and put something in the UN high-level meeting resolution which explicitly addresses this topic of working between the government, the public and the private sector.
Perfect. Aminatu?
I would say advocacy. I think it is one of the most powerful tools that we are using to achieve our mission of health equity. Smart policies and robust resources can make all the difference between a promising idea and an inclusive and sustainable health system or program. And here, the private sector has a huge role to play. But for us to make the private sector daring or willing to go into that, we need to engage decision maker and holding them accountable. And it goes with a trustworthy partnership between the private and the public sector is, in my sense, the driver for this aim.
Thank you. And Vivian?
I'd say lastly, probably leveraging the strengths of the private sector and closer integration between the public and the private. Where you see that data is the new oil, The private sector has a lot of data that has not been integrated and used in the public sector. So with the private sector sharing data it has, this was one of the integrity projects I gave example of. Part of it was also using them collecting data at the community level. So using data from the private sector to support the public sector in better decision making.
Amazing. And I'm going to keep you guys here on stage and open it up to audience questions. Does anyone? Oh, wonderful. We've got a burning question.
It's a question for David. Hi, Ian Barton and Hassan and Management Sciences. So Southbridge and Management Sciences for Health are actually the pilot for this African Working Capital Fund, which is one of the most innovative things that we're seeing. I'm also involved with Njani Clinics, which MSD for Mothers has been a great supporter of. We've got 150 clinics in South Africa, 100% women-owned, and 82% of the employees are women. So, but both of these initiatives don't have any partnership with government. What they're doing is they're addressing the unmet need of the population who is both willing and able to self-fund primary care. Twice this week I've heard people refer to out-of-pocket spend as if it was a sin. Self-funding of primary care is a route to access of quality care. How do we overcome that prejudice, David? How do we get people away from this thing of thinking that out-of-pocket spend is bad?
Well, I don't think it's out-of-pocket spend itself that's bad. I think it's catastrophic health expenditure that's bad. So we need to make health systems more efficient. I don't think any of the WHO well, I know people do talk about out-of-pocket expenditures if it's really bad, but it's a reality. So what we need to do is to try and get the price to the end user down and to be more efficient.
Hassan?
Yeah. Well, I have also the same concern about this out-of-pocket question, because if we take out, philanthropy and bilateral aid, everything is out of pocket, because at the end of the day, it's going through either social security system or through your taxes, and at the end of the day. So the question is about the efficiency of the expenditures, and how do we make that as efficient as possible from the public sector or the private sector. And usually it's about who's taking the risks and who's having scale. So public sector is actually always going to be the cheapest way to deliver care, but it has to be efficient, because you have scale effect around it, etc. But the private sector is going to be more efficient when it's becoming agile and having ability to negotiate or to pay differently, etc. And that's where we need to find the right balance between public and private sector. And it's not about out of pocket or what, but who is the better actor, operator, and a risk taker in this situation.
Any more questions?
Yeah, hi, Ed Kelly. I work with an organization called AppyCheck, formerly at WHO, where I was director for service delivery, and where we worked a lot on quality. So I guess my question is mostly for Viviane, but it could actually be for the group. Having done lots of panels, normally you talk about what worked, so that's great, thank you for that. I wonder particularly, we're working on a project where we're bringing injectable contraception to women, particularly post-COVID. Outreach services have not been restarted. It's quite difficult. I wonder, and the involvement of pharmacists and community health workers is going to be key for lots of services, that's included. I wonder if you could say a word about things that either didn't go well or were unexpected in trying to involve, for instance, pharmacists in delivering services, and that could, are clinical in nature and involve patients, and for which people are concerned about quality, sort of things that might not have, you didn't expect, that didn't go well.
That's a really good question.
I'll take that question from the perspective of the focus of the Integrity project, which was specifically on increasing access to family planning services. And working with the community pharmacists and PPMVs that the teams worked with, one of the things they ensured they did, and it's a continuous process, is in training the community pharmacists and PPMVs in delivering those family planning services specifically. However, having said that, we know that community pharmacists and PPMVs historically have delivered a broad range of services anyway. And I started off by mentioning the health-seeking behavior in Nigeria. Because of poor access to healthcare, people often go to them. And they may not sometimes have the ability or qualifications to deliver a broader range of health services. So there, absolutely, there probably could have been challenges. But for specifically the Integrity Project, they ensured that working in the Pharmacists Council of Nigeria, those specific services, they were given the requisite training to ensure they delivered them. But yes, it probably would have been, if they look at other health interventions that they may have tried to deliver. I mean, I don't have, we don't have data on those because these are things you don't know what could have gone wrong. Yeah, so absolutely, I think the key thing is, the key thing really is ensuring that in every rural area or in every area, people have access to quality service, whether it's through the community pharmacist or through a primary healthcare center.
We have time for one more question, and I think, do we have two? We could try and squeeze in two, but we've got one right in the front here.
Okay, I feel like this corner of the room might be monopolizing things a little bit. President, Management Sciences for Health and Chair of MedSource. My name is Marion Wentworth. I have an observation based on the work that both MSH and MedSource have done, which is that we have a tendency when we're trying to go to private sector to talk about scale and to try and get big things done first. At MedSource, we were really targeting mid-size and small pharmacies and mid-size and small hospitals to create affordable medicines at high quality. And we automatically, without trying and applying a gender lens, got to 25% female-owned businesses, and I don't have the data on the number of women who are actually working there. In Tanzania, when we worked with drug dispensing outlets for years and years and years to accredit them and get them to a place where they could deliver quality throughout that country, 90% of the drug dispensers that were trained through that project were women. Again, it wasn't because we did a gender lens, it was because we didn't just go to the biggest organizations in the country and start there, because those do tend to be dominated by males. Thank you.
Thank you so much. Did we have a question at the back? Okay, last call. Okay, we have one right here.
Hello, Sumiko Tanaka-Push with Causal Foundry. It's an AI and machine learning platform funded by the Bill and Melinda Gates Foundation. So Vivian, you were talking about the need to share data. I'm wondering if you have any insights into how to incentivize data sharing between private and public sector.
Interesting question. How to incentivize? I think, obviously, the private sector, I mentioned, has a critical role in filling those gaps where the public sector cannot fill in. The incentivization for the private sector is by building those stronger bridges, because the private sector has the capacity and innovation, whereas the public sector, that's where you often get the volume and the larger number of patients. So by closer integration, I think, between the private and the public sector and incentivizing that sharing of data, then it's in the interests of the private sector, because they'll be better integrated with the public healthcare system, where they're able to work with the government in delivering broader range of services where they have the expertise. So I think the incentivization for the private sector is they're able to leverage on the volume of patients that, or healthcare needs of the public sector to support the bigger health system. So I think the incentive for them would be that closer partnership and integration with the public sector and government institutions. Yeah.
May I chip in on that one? We are working in the suburb of Dakar on an urban health approach and working with the Senegalese Alliance of Private Sector, and it is really understanding why is that they can't share the data. And most of the time says this is time, and time is money for us, for our facilities. And one of the incentive is also how we use the community health workers to be the link between the public and the private. And many of us, we see the community health workers as free labor. It shouldn't be. And this is why actually it is a problem. It is time. We need to pay that time as long as we are paid for the work we are doing, and just respect more the role and the contribution of the community health workers, and then there they can play a bigger role in connecting those dots.
Can I just say one thing? We've actually, the data issue is a major problem. I think it stops the integration of the public and the private systems. So we've got a project on it. We're just about to kick off. And we'd love to hear from anybody in the room who'd like to collaborate with us on how we can improve data interoperability between the public and private sector.
Thank you so much. So you heard from David. If you do want to work on that, please do approach him. He'll still be around after this session. And we've come to the end of this session. Thank you so much for all the insights. Really appreciate how we managed to dig into this issue with all the speakers. Thank you.
Thank you very much.
Oh, sorry, we've come to the end of the panel. May I ask you to sit down? We've come to the end of the panel, but not the end of our event. Thank you so much. To end the session, we're going to just have a few closing remarks. I'm going to call on stage Tayo Erogbogbo, who is the Director of Multilateral Organization Engagement at MSD and Advocacy Lead at MSD for Mothers, as well as Suraya Dalil, who is the Director of the WHO Special Program on Primary Health Care, former Senior UNICEF official, and former Minister of Health in Afghanistan. Thank you both.
I can start. Okay. Good morning. Good morning, colleagues, ladies and gentlemen. Very nice to meet you, and this was such a constructive discussion. So my trial to summarize and to close this session, and I'm sure you will add on that one if I left anything. I think I will start with a story from my experience. We are three sisters, and one of my sisters, 20 or 21 years ago, we were in Afghanistan, and she was pregnant, and she gave birth at home, and she called an obstetrician to come and help her. There was a maternity hospital nearby, very, very close, but she didn't choose to go to the hospital, and she chose to give birth at home with an obstetrician that she was confident in her. She had confidence in her. And why she didn't go to the hospital? She didn't go to the hospital. It was very obvious, the reasons for us as a family, because of quality of care. Because it was winter and the hospital, the maternity ward didn't have enough equipment to keep it warm and for mother and baby, and also for hygiene issues. But it was overall about the quality of care, that she was not sure that she will receive adequate care, including at night or after office hours or at weekend, if she has to go there to seek care. And I think that's why we have been hearing a lot this week about trust. And this was an example of trust that happened. And that's why sometimes patients, including women, they choose to go to private providers, midwives, and obstetricians, and so on, for childbirth. So how we can, they are a stakeholder in many developing countries, private sector is a powerful stakeholder, and they are in that environment in different capacity and in different roles, as a pharmacies, small private clinics, physicians who work after hours in their clinics, diagnostic services, labs, some private hospitals, and so on. So the scale and the diversity of private sector is also large. I agree with the comment that both sides, public and private, do not know how to work with each other. And I'm glad to see that it's also a reality in many other countries. How we can make these two parties closer to each other is as many speakers said before, is bringing them on board right from the beginning, not only at the stage of data collection and reporting, but at the stage of planning, shaping the priorities for the health sector, setting the goals at the stage of formulating the strategic plans and the national plans. And within that, of course, sharing data, having regular coordination mechanisms, sharing data and other informations, and have developing or setting up institutional arrangement to make sure that this kind of coordination and collaboration is formally in place. When it comes to women and children, I gave you two examples. For family planning and contraceptives, pharmacies were a big point of contact in the countries I worked for women to go and to receive contraceptives, but also in terms of acute flaccid paralysis for the eradication of poliomyelitis. The poliomyelitis eradication effort team, they contracted physicians, neurologists, psychiatrists, and others in Afghanistan to report any case of acute flaccid paralysis, because some of those paralysis may report to the physicians first in the private clinic and not in the public sector. With regards to what didn't work, in my experience in Afghanistan, again, a developing country, fragile and all of that, what didn't work when we had some stability was that setting public-private partnership right. We failed to do that because it required a lot of alignment with Ministry of Finance, for example. It couldn't be only a Ministry of Health endeavor. It has to have some regulations in place first, because it's not only for health services. Ministry of Finance was saying it could be for infrastructure project, it could be for others, so we need to develop the regulation first. And that was very time-consuming process, aligning with the Ministry of Finance, but where the Ministry of Health was ready to go into feasibility assessments and start feasibility studies for the future private-public partnership hospitals and so on, but it was not successfully materialized. So I also want to touch on the medical education. Private sector play a great role in medical education, in training, pre-service training of physicians and nurses and midwives and lab technicians and pharmacists and so on. So they are also play a great role in terms of medical education in many countries. Thank you.
So I guess my job is to try and sort of pull some of this together and to also mention why MSD and MSD for Mothers specifically, which is our philanthropic initiative to help reduce maternal mortality across the globe, while we partner with the Country Connector, a number of the people that you heard up here speaking. From our point of view, I think, and trying to pull together the things that you've heard here, when we first started the initiative over 13 years ago, what was very obvious was that there was no way in which the public sector could do this alone. The reality is, if you follow a woman in a lot of the countries where the issue around maternal mortality is greatest, my own country, Nigeria, India, and others, women are moving between public and private. They're seeking care, information through different sectors. That is the reality they're experiencing. One of my seniors, as we like to call him in Africa, Dr. Gitinji Gitai, would often say, the women can go for a referral in the public sector. They go to diagnostics in the center next door, which is privately owned. They may come back to the same original clinic to see the same doctor to provide the results, etc. But they may or may not have access to the service they need within the hospital, so they may need to go back into the private sector, etc. But this is highly inefficient. The challenge is that basically we're not thinking strategically about the capacity that's within our health systems. And as David mentioned earlier on, the physical space is really shrunk. It's not so like it's shrinking, it really has shrunk. And increasingly that's going to get even more challenging given climate change and the demands that we have in a lot of these settings. So the big question we have is, how do we use all the resources we have in our health systems in a more strategic manner? And the private sector, as we've heard earlier on, is already playing a massive role, but they're seldom really integrated in a strategic way to deliver services. We have one goal in terms of the public health agenda. We're trying to save the lives of women in terms of addressing maternal mortality, or the lives of our newborns and children. That should be our focus. And the question should be, in terms of trust, how do we harmonize around that single goal and think to ourselves, okay, how do we therefore work together in terms of, yes, providing data? It's not necessarily a challenging thing. The technology and the issues are there. The question is whether we want to actually take those bold steps in terms of making it work. And again, the solution in terms of how to make those work are there. So our call to action really is, in line with the Country Connector and our support around the Country Connector, is how do we really support countries in thinking in a pragmatic manner about how to bridge some of these gaps. We also support the I3 initiative for the very same reason, because we know the capacity is there within these countries who are really stretched. My own country, Nigeria, is dealing with security issues. If you go to the government and you say, okay, look, we need to get to a budget declaration, can we have 15%? The Minister of Finance will say, okay, well, where do you want me to cut? Is it the insurgency across the north? Is this a lack of education across the country? We're really in a difficult position. Not least, 70% of Nigeria's current revenue is going for debt repayment. So that's the reality on the ground. In that context is where we need to be able to deliver services. So again, the call to action is, how do we support countries to be able to better strategically integrate the private sector in their responses to health services? And the number of different ways in which I think David mentioned earlier on that the Country Connector is working to help the countries in terms of those priority areas that they've elevated as the critical areas for care. So I'll stop there. The only thing is that please connect with David and the rest of the team to see how we can really work together. It's not a job for any one company or one organization. So thank you very much also for coming in.
Thank you both so much, and thank you all for sticking with us throughout the programming and having these important conversations with us. We also want to make a final thank you to our partners, MSD for Mothers and the Country Connector. Thank you, and enjoy the rest of your morning.